Thank you, Mr. Speaker. Will Mr. Gottfried yield just for another couple minutes?
Certainly.
Mr. Gottfried yields.
Last topic I wanted to go into, we finished talking about that $45 billion. This isn't a question, but I would note, when you take the personal income tax in New York State, maybe take out a star somewhere in that neighborhood. So maybe that's a way to shoot $45 billion into our economy. Just get rid of our personal income tax. But I want to just go into just one of the recurring issues we've seen in New York State. Would it be fair to say that the, best glimpse into what it would be like for New York State to run our entire health care system would be the way we administer our Medicaid program?
Could you restate the question?
Would it be fair to kind of extrapolate, our administration of our Medicaid program to being, how we would administer something like this when we were administering the entire healthcare system in the state?
There are some aspects that might be mechanically similar, but the profound difference is that it would be run as a program for all New Yorkers, rich and poor alike, not just for poor people. And unfortunately in this country, programs for poor people tend to be poor programs and the way poor people are treated by programs is different from the way you and I would want to be treated by an agency we were dealing with. And because you and I and Michael Bloomberg and George Soros and other wealthy New Yorkers would be in the same boat with this program, it would treat all of us a whole lot better. So I don't know if that's what you were getting at. Actually, the Medicaid program is run a lot more efficiently than health insurance companies, in large part because it doesn't have to spend money on advertising and a lot of other things that insurance companies do. Also, while people write a lot about fraud in the Medicaid program, insurance companies don't like to tell us about all the fraud that goes on in their programs. And unlike the Medicaid program, they don't have police powers to go after that fraud. And so, in fact, the Medicaid program can and does come down a lot harder on fraud than in insurance plans. And that would provide additional savings in the New York Health Act.
Yeah. That was where I wanted to go with that question, though. So waste, fraud, and abuse, and I certainly understand. We've heard wide-ranging estimates of what that number might represent within our system. There's been audits, there's been studies. I know the comptroller released a report last year looking at this issue. But I know one of the features of this plan is, you wouldn't have that local share, right? So the full gamut of anything we're losing to waste, fraud, and abuse would be borne at the state level, and presumably it would be the state who would have the incentive to combat that. So is there anything...
Yeah, well, currently, the tools we have for going after Medicaid fraud and the like are overwhelmingly state tools. By the way, one element of Medicaid fraud, it's a fairly small part of it, but which is people who are defrauding the system because they're fraudulently trying to say they're eligible. That would go away because we would all be eligible. Nobody would be fighting to prove, to hide their assets, what have you, because we'd all be eligible. Provider fraud, the system has actually been doing for the last 9 or 10 years or so a much better job at combating provider fraud than ever before, with stronger tools than the state ever had. and dramatically stronger tools than any insurance company has. And again, if the controller was doing studies about provider fraud against private insurance companies, we'd be seeing really horrendous reports. But because we say, oh, that's not taxpayer dollars, we don't do those analyses, and the government doesn't tend to go after that kind of fraud. And so there are fairly hefty rates of fraud in private insurance, more so than in Medicaid.
Okay, so, but my question then would be, especially on the provider side fraud, is there anything new coming in with this bill? I know there are existing things in place to try to combat that, but anything new regarding this bill and its administration that we would take advantage of, whether it's new laws, new technologies, to ensure that the services that the providers are going to bill to this state system actually took place?
Yeah, well, first of all, one common kind of fraud, which is to say double billing, where a provider bills maybe Medicaid and an insurance company, or sends bills to two insurance companies because you've got primary coverage, secondary coverage, sometimes it's not clear who's covering. All of that fraud, whether it's intentional or not, disappears because there would be no duplicate places to bill. So that category of fraud, the plan would also eliminate overnight. The tools that New York has, the prosecutorial and investigational tools, the computers for analyzing care patterns, et cetera, all of those tools would work a lot better if they were applying in a single payer system than they do today. So in that sense, yes, it would strengthen the anti-fraud tools that we now have.
Okay. Mr. Speaker, on the bill.
Thank you, and thanks for the question.
On the bill, Mr. Roth.
Thank you, Mr. Gottfried. Just quickly, so, you know, we've done this bill on the floor before. We've brought it up a number of times in the Health Committee since I've been here. And one of the things that I always find interesting is obviously this is a discussion about trying to provide care to as many people, and adequate care to as many people as we can in this state, hopefully all the people of this state. Yet we many times discount opportunities to try to combat those issues of waste, fraud, and abuse. I think particularly in something like this, it would probably be even easier than ever to go in and come up with a very technology-based system to make sure the provider side fraud does not happen, but we're not really going down this road here. There have been things that have been proposed in the past in the Health Committee that were really kind of, you know, just brushed aside as unimportant while we talk about this. Meanwhile, every dime that goes out the window to a provider for a service that was never billed, or to somebody who is improperly billing the system, is a dollar that could have gone towards providing care for a New Yorker who isn't currently getting it. So that's going to continue to be a concern of mine, one of the many concerns I have on this bill. But I think that going forward when we discuss these issues, we really have to think about, so if we have a system that we put in place, and Vermont was mentioned earlier, and we talked about that their issue, basically, they looked at it and they figured out that there would be too much cost. In other words, they'd probably have to raise taxes too much to pay for it. He didn't want to basically send that down the pipe. Well, we're basically, if these projections don't materialize, we're basically just putting it in administrative that this is going to get paid for one way or another. So administratively, those rates are going to come down on New Yorkers, and they're going to have to pay them. So that is something that is of major concern to me. You know, I certainly think that the graduated structure of this may be more effective than whatever they tried to do in Vermont. but whatever those rates are going to be, they're going to have to be increased commensurate with whatever the cost truly ends up being. And we can project it, but I don't know that we can truly predict it. And if some administrator somewhere is going to have to keep jacking up that number to meet the financial needs of this program, who knows where it's going to end or how high that rate is going to end up of this premium, which we know is really, at the end of the day, a tax on our New Yorkers. So I'm going to be casting my vote in the negative. I know many others will as well. So I thank the chairman for the discussion on the bill, but I think we have a long way to go to proving that this is the right solution to the problem. Thank you.
Thank you, Mr. Robb. Mr. Goodell.
Thank you, Mr. Speaker. Would the sponsor yield?
Mr. Godfrey, would you yield?
Certainly.
Thank
Sponsor
you.
yields.
And I have my Constitution with me.
Thank you. I have mine as well, so things should go well. Under this proposal, as you know, right now, all of us here in the chamber have a health care plan. Has various limitations and co-pays and deductibles. Under the plan that you envision, would there be restrictions on the coverage, health care coverage that would be available to New Yorkers?
Well, let me answer that a little differently. The benefits under the plan would be everything that is covered by any one of the following: Medicaid, Child Health Plus, Medicare, the state public employee benefit package, or the mandates in the insurance law, plus anything else that the plan would choose to add. I haven't had anybody ask me, would it cover X, where the answer wasn't yes.
Okay. So just as an example, it would cover full dental, presumably?
Yes, it would cover dental, vision, prescription drugs, etc. Yes.
Acupuncture, hopefully?
Yes.
I didn't want to needle you about that, but I wanted to make sure that was in there. Yeah. And there's no deductible, no copay. Am I correct? Yep. And as you know, right now we have the Medicaid program, which covers a lot of residents. The hospitals all across New York State and the nursing homes have complained that the Medicaid reimbursement rates are below their actual costs. And as you know, we've struggled with hospitals that are actually going out of business. Last week, I think we had a bill that tried to address some of the hospitals that are going out of business because the reimbursement rates were too low under Medicaid. Do you envision under this plan that the reimbursement rates would be substantially higher?
Yes, and the proof of that, and by the way, when St. Vincent's Hospital on the west side of Manhattan went under, it wasn't because Medicaid wasn't paying them enough, it was because commercial insurance plans weren't paying them enough. But until 20 years ago, in this state, the Medicaid rate and the Blue Cross rate for hospitals, and in those days Blue Cross was almost everything in the insurance world, those two rates were statutorily locked together. So my gallbladder, if I were having gallbladder surgery, and a Medicaid recipient's gallbladder would have been paid for exactly the same price. As a result of that law, because upper income New Yorkers wanted to make sure their hospital was well paid when they went in, because they had Blue Cross, the Medicaid rate was dramatically higher, relatively speaking, than what it is today, even though physician rates were in the toilet, because physician rates under Medicaid weren't tied to anything. And so we have historic experience to show us that when the rich and poor are in the same boat, the hospitals get paid as if the patients were all rich people.
And
that's how this would operate.
And am I correct that you estimated that the cost of bringing up the reimbursement rates to a profitable level would be in the range of $26 billion?
I'd have to look back at the report if that's exactly the number, but it as to what is estimated for increased payment rates, but it's in that ballpark.
Okay.
Yeah.
And of course, more people would be covered, right? You mentioned that there were a couple 100,000 people. You'd estimate around 5% that were not covered currently. So we would add all those people in?
Yeah, let me correct something. The 26 billion number is the total of all of the increases in spending contemplated by the bill, not just the increases in rates to providers. It's an element of that 26 billion. But yes, we are assuming about 1 million or so New Yorkers who now do not have coverage will have coverage, and people who have major gaps in their coverage will no longer have major gaps in their coverage. Yes.
So to summarize it in a very simple way, we would dramatically expand coverage. We would now have full optical, full dental, something I appreciate, having just come back from the dentist yesterday and picked up most of the costs myself, even under the dental plan that we have,
Yep.
which is really a misnomer. So we'd have great coverage. I assume probably the best in the nation, one of the best in the nation in terms of coverage. We'd extend the coverage to 1 million residents in the state of New York. We would dramatically increase the reimbursement rate for hospitals and for private physicians. And I know many physicians have complained under the Medicaid program it's hardly even worth seeing, so we would increase that so it would be profitable for them. Is that a reasonable summary of how we would deal with this on the payment side and coverage side?
Yeah, I think so. As I said earlier, if you go through the numbers, the 71 billion in savings, the roughly 26 billion in increased spending, that's where the net 45 billion savings comes. And it works because of the because of the 71 billion that we are now spending that does not produce value added in healthcare.
Now, part of that...
And, I'd be happy to sit down with anybody and go through those numbers item by item. It's hard to do in floor debate,
Sure,
but
sure.
I think they hold together totally, and I have not seen anybody document a rebuttal to those numbers.
Well, right now, part of the overhead you're talking about presumably are all the licensed agents that sell health and accident insurance, and I believe that number is about 118,000 licensed agents, and there's another 8,000 plus registered brokers, and there's another, sorry, I didn't have the number memorized, there's another 146,000 people, I think, that are employed altogether in the insurance carrier and related activities. So part of the overhead that I understand you're saving is that we would no longer need the services from those people. Obviously, we don't need people selling us health insurance plans if we have a single-payer system, right?
Okay, those numbers sound like numbers for the entire insurance market, all kinds of coverage. If you're looking specifically at health insurance, the numbers are a small fraction of that.
Well, I just note that from the Department of Financial Services, they said there are approximately 118,020 agents licensed, authorized to sell accident and health insurance. And, of course, they would no longer be selling health insurance under this proposal.
Well, but it doesn't mean they wouldn't be selling insurance. It means this would not be one of the products they're selling.
How many individuals currently work for private insurance companies that would no longer be employed in a private insurance company under this bill?
Well, as I said earlier, the number that's in our report and that I've seen in other documents is 23,000.
In order to pay for this program, we're talking about a payroll tax, and am I correct that you would anticipate that that would be split 80-20, 80% employer, 20% employee?
At least 80% employer. The employer could agree to pay more, which would usually happen through collective bargaining.
I see. And to ensure that the coverage is kept current and that the payment rates are high enough, we have these a board of trustees in charge of reviewing the program and making recommendations. Is that correct?
Yes.
And that the board of trustees has representatives from the hospitals, doctor representatives, am I correct? Union representatives, employee representatives. Basically, everyone who's getting money out of the system is represented on the board of trustees, correct?
Well, it would also have a couple of people with expertise in healthcare finance.
And
people
are there
representing
any
consumers?
Is there any designation that the employers who are paying 80% of the cost have a designated representative or representatives?
No.
So the people who are getting paid are in charge of the program, and the people who are footing the bill have no designated say. Isn't that a system that's designed to drive up costs?
Well, I don't think so, because ultimately it is a system that is accountable to the governor and the legislature. We would be enacting and periodically revising the funding mechanism, and it would really be the, today in the coverage world, in almost every part of coverage, all of the pressure is downward against improving coverage. In this system, you would have a balance of pressures. Our constituents would want to keep the premium, or you would call it a tax, would want to keep the premium down, but our constituents would also want to keep the quality of the coverage up.
Sure, and our
So there would be that balance of pressure, regardless of who's on the board.
And our constituents under this plan, if you're referring to the individual voters, would be paying 20% on the payroll tax or less, and businesses would be paying 80% or more. But let me ask a separate question. Private health insurance, I'm a little confused. Let's say my doc, for some reason, doesn't like the reimbursement rate under this program. Can I supplement that in order to make sure that he sees me? Or can I buy private insurance that pays a higher reimbursement to guarantee coverage? As you know, one of the things that's been happening lately are these boutique practices, if you will, where you pay a premium and in return you get premium care. Can that continue?
Well, first of all, just on the previous question, about a third of the board members are not designated as coming from any particular group, so the governor or the legislative leaders could appoint business people. But on the question of whether doctors are allowed to, on the side, bill more for their service, like with traditional Medicare and Medicaid, the answer is no. And the reason for that, and I think there's a lot of commercial insurance with similar requirements for people in their network, the reason for that is that if it is very important that the doctors serving wealthy New Yorkers have the same stake in the quality of the plan as the doctors serving middle-income and lower-income New Yorkers. And if wealthy New Yorkers and their doctors no longer have to worry about whether the plan pays adequately, the plan will very quickly deteriorate, and there will be two tiers of care, one for people who can pay out of pocket and the other for everyone else, and that's what we're trying to get away from.
In my county, I border Pennsylvania on two sides, actually, on both the west and the south. And many of our counties border Pennsylvania or New Jersey or Connecticut. What happens if an individual lives in our beautiful state of New York, but works, say, in Pennsylvania or New Jersey or Connecticut or wherever, has great health coverage under their employer's plan in Pennsylvania, are they exempt from paying the cost of this plan?
No, because since they live in New York, they would be benefiting from the plan. The way the premium system would work is if is one of three things would happen. Either their employer would voluntarily choose to pay the much lower New York health premium than the much higher premium that the insurance company charges. And I think most businessmen and women know the difference between lower and higher and would choose to pay the lower one. Or if they are a company with sufficient contacts in New York to be subject to New York law, they would be required to pay the New York health premium on behalf of their workers. If none of that works, then for that individual worker, they would be treated as if they were self-employed and pay the 10%, which means they would have a strong incentive to encourage their employer to pay the lower New York health premium rather than the higher premium that they're spending for other workers in the company.
Thank you very much, Mr. Godfrey. I appreciate your comments.
Thank you.
Mr. Goodell for a second time.
Thank you. On the bill.
On the bill.
The explanation we're given for this plan is great. I mean, think about it. We dramatically increase what we pay for all the health care providers. We dramatically increase what we pay for hospitals and doctors and dentists and everybody. And we dramatically increase coverage. So everyone gets full dental. I'd love that because I'm going through that process. And everybody gets full optical, acupuncture, you name it, you got it. That sounds great. And we add 1 million patients to the program. Great. Now, granted, I have a math degree, and not everybody doesn't. But I can tell you, if you dramatically increase how much you pay out, and you dramatically increase the coverage, the options that are covered, and you dramatically increase not only how much you pay out, but how many people are covered, and you eliminate any deductibles, and you eliminate any co-pays, and you eliminate any of the pre-approvals that we have in our system now that are designed to keep the costs contained, and you then, on top of that, put in an administrative structure. A board of trustees consists of people who are paid by the system, consisting of doctors and hospitals who want more money out of it, consisting of employees that want, like all of us, to increase the coverage. And you fund the program by a payroll tax, but you don't put any designation that anyone who actually pays for the cost has to be on that plan. If there's anyone in this room that really thinks the cost of this program is going to go down and it's going to be less than what we pay in health care coverage, I would suggest you go back and take out all your smartphones and start adding up the numbers. You can do that. There's an app. It's called Go to Bankruptcy. Now, I wish that we could all live in the nicest house in the neighborhood. I also wish that we never had to pay taxes. I also wish that we could buy whatever food we wanted and drive whatever car we wanted. And I wish that we could have unlimited health care, preferably at somebody else's expense. But that option is not available to us. And so maybe we should look at ways we can make health care less expensive in New York. Maybe we as a legislature ought to look at the fact that we have over $4 billion with a B, dollars in taxes and fees on health care. That's right. When you go to the hospital and you're really sick, we have a special tax on that. Yeah, it's a sick tax because you pay it when you're really sick, and it's over 9%. You buy a health insurance policy in New York, guess what? We tax that. The health insurance companies, oh yeah, we tax them too. Cover life's assessment, extra fees and expenses, $4 billion in taxes and fees on health care. So do we want to solve the problem? Let's look at how the private market solves this problem in all the other states around the nation. They don't nationalize health care because when you look at the world, you realize the national health care system is not the most efficient. Unlike any other business, we don't allow individuals in the state of New York to buy a health care policy that's tailored to their health care needs. You can't buy a simple, inexpensive policy in the state of New York. We make that illegal. You can't buy a policy unless it has over 58 mandated coverages, coverage you might not ever want or ever need. Imagine if we applied that policy to buying a car. And we as a legislature said every car has to meet certain standards, not just safety standards, but we want the right seats, the right options. And by the time we're done, you wouldn't be able to afford to buy a car either. So maybe rather than dramatically increasing the cost of the system and doing it in a way that will bankrupt not only the state but our businesses, let's look at ways that we can work together on a bipartisan basis to make health insurance in New York State more affordable and more available to everyone by taking the burden of the state itself off the backs of the patients, by reducing the taxes, allowing more options, streamlining the system, and improving overall health care. For those reasons, I will be voting against this bill and urge my colleagues to do the same. Thank you, Mr. Speaker.
Thank you, Mr. Goodell. Read the last section.
This act shall take effect immediately.
The clerk will record the vote. Mr. Rea to explain his vote.
Thank you, Mr. Speaker. I rise to explain my vote. As we mentioned earlier, Vermont recently abandoned their effort to implement the single-payer health care plan. Its chief proponent, Governor Peter Shumlin, summed up why it couldn't work, and I believe, quote, he could not reasonably support or urge the legislature to pass the tax rates required to fund the program, and the potential economic disruption and risks would be too great to small businesses, working families, and the state's economy. The problem here is Vermont already has a near universal health care system, number one. Number two, their program was less ambitious than what we're proposing here with New York Health. I don't think the small businesses and the many taxpayers deserve to be the guinea pig on a program that has far too many question marks and uncertainties. If health care keeps going up the way it's going at the rates it's going, someday this might actually make sense. But I don't think we're there yet. I vote in the negative. Thank you, Mr. Speaker.
Mr. Rea in the negative. Ms. Glick to explain her vote.
Thank you, Mr. Speaker. I just want to thank the sponsor for bringing this forward. I think that, like Hawaii, which actually implemented a similar program a couple of decades ago, There were some initial increases in cost, but thereafter, they directed their efforts towards well care, and the life expectancy in Hawaii is substantially greater than ours, maybe not just because of their single-payer plan, but it did make broad access to well care available to all Hawaiians, and I think we should do the same for all New Yorkers. I withdraw my request and vote in the affirmative.
Ms. Glick in the affirmative. Mr. Cahill to explain his vote.
Thank you, Mr. Speaker. I, too, rise to congratulate and compliment the sponsor of this legislation for his tenacity in carrying out this debate over a course of years that exceeds, and I know we're not supposed to mention members' names, but the life of Mr. Skoufis, for example. This bill was an innovative, good idea when it was first introduced, and it remains so today. We are watching this country come together in different ways to try to address health care, and we're seeing the complexities of trying to superimpose one system on another. And really, we all know what the answer is. We all know that the solution that young Dick Gottfried proposed many, many years ago is a good idea in 2016. I withdraw my request and vote in the affirmative again.
Mr. Cahill in the affirmative. Ms. Lifton to explain her vote.
Yes, also to explain my vote, Mr. Speaker, I also want to commend the sponsor. Every country, that is most countries in the world that have instituted single-payer health care, have better outcomes and have pay less money per person for health care. So this is a proven system. It's not theoretical, and we should do it here in New York State and lead on the issue of single-payer in this country. Thank you, Mr. Speaker.
Ms. Lifton in the affirmative.